My name is Michael Giverts. I'm the Medical Director of the Heart Transplant and Mechanical Circulatory Support Program at the Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School, both in Boston, Massachusetts. I'll be speaking to you today on the topic of heart transplantation. I have no disclosures related to this talk or this topic. Heart failure is a progressive disease. This is a dramatic illustration on this slide. On the left here, you see a normal adult human heart, and on the right, you see an explanted heart from a young physician with idiopathic dilated cardiomyopathy who underwent successful cardiac transplantation. This process of enlargement and dysfunction of the heart, so-called cardiac or ventricular remodeling, typically takes place over months to years, during which time we often are following these patients very closely for management of their heart failure. It's our job as advanced heart disease cardiologists to determine when patients are sick enough that they should be considered for advanced therapies such as mechanical support or heart transplant. Some of the markers of advanced disease and poor prognosis which we look for are listed on this slide. We have excellent guideline-directed medical therapy to treat patients with heart failure, but at some point, patients become intolerant to neurohormonal antagonists such as ACE inhibitors or beta blockers due to cardiorenal limitations such as hypotension or worsening renal function. In addition, many patients with heart failure are treated with diuretics to maintain euvolemia, but at some point require increasing doses of diuretics or combination diuretics to try to maintain optimal volume status. This also is a marker of advanced disease. Many patients start with left ventricular failure from a myocardial infarction or valvular heart disease, but over time may develop failure of the right ventricle and secondary pulmonary hypertension. Again, these are indications of more advanced disease and poor prognosis. Ultimately, patients may reach a period in which they are declining more rapidly to really end-stage disease. And these may be marked by things such as cardiac cachexia or frailty, particularly in older patients in which heart failure is so common. Recurrent hospitalizations is also a marker of advanced disease. The one-year mortality rate after a single hospitalization for heart failure is nearly 30%, particularly in patients over the age of 65. But once a patient has a second, third, or fourth heart failure hospitalization, their median survival decreases to somewhere between 6 and 12 months. And lastly, there are biochemical markers of end-stage or advanced disease, such as chronic kidney disease and some of the associated abnormalities on blood testing, such as hyponatremia, anemia, and hyperuricemia. In this observational study of patients with ambulatory advanced heart failure, Garrick Stewart and his colleagues followed approximately 170 patients with class 3 or class 4 heart failure who had had at least one heart failure hospitalization in the prior year and one other high-risk feature. What's most notable about this ambulatory heart failure population is the outcomes at 12 months. As you can see here, only 47% of this cohort remained alive on medical therapy after 12 months of follow-up. Clearly a high-risk group that should be considered for advanced therapies if they meet inclusion and exclusion criteria. Well, let's talk a little bit about the history of heart transplantation. Little known in this field is a surgeon by the name of Vladimir Demikov, who was based at Moscow State University in Russia. And in the mid-20th century, from 1946 to 1958, Dr. Demikov performed 250 intrathoracic heterotopic heart transplants in dogs using over 20 different techniques. Nearly 30% of his dogs survived at least 1 week, and the longest survived just over a month. He was considered to be the first surgeon and clinical scientist to implant an auxiliary heart in the thorax. Interestingly, Dr. Demikov's research was not published in English until 1962. Many of his studies were published posthumously. Now, around this time, Norman Shumway and Richard Lauer, really considered the fathers of human heart transplantation, began a groundbreaking series of experiments at Stanford University in Palo Alto, California. In 1959, they performed the first orthotopic heart transplant with full recovery of the dog, who lived 8 days. In the 1960s, developing a groundbreaking program performing approximately 300 transplants in dogs. And in 1966, Lauer in the laboratory resuscitated human hearts in baboons, confirming for the first time that the human heart can be stopped, removed, resuscitated, and successfully transplanted. Lastly, they applied the biatrial technique, which became the first reproducibly successful technique for actually performing orthotopic heart transplantation. And this, of course, paved the way for human transplants. Now, Drs. Shumway and Lauer are poised to perform the first world's heart transplantation, but this great achievement actually fell on the shoulders of the surgeon shown here on the right. This is Dr. Christian Barnard in Cape Town, South Africa in December 1967, just over 50 years ago. The patient on the left here is the first patient, a 55-year-old man with diabetes and end-stage ischemic heart disease. The donor was a young woman who was killed in a motor vehicle accident. This photograph was taken approximately a week after surgery. You can see that the patient is doing reasonably well. Unfortunately, this first patient lived for only 18 days, dying of pneumonia in the face of aggressive immunosuppression. Little known, however, is the fact that 1 month later, Dr. Barnard's second patient lived for nearly 19 months following heart transplantation. And Dr. Barnard really got most of the early notoriety for this really landmark clinical and surgical achievement. But really it was Dr. Shumway and Lauer in the program at Stanford that continued on the experimentation and ultimately the clinical development of this field of medicine. Well, looking here at the worldwide heart transplant volume, you can see that the volume was very small throughout the 1970s and even into the early 1980s as shown here. And that was primarily due to the fact that the outcomes were really quite poor early on in the clinical history of human heart transplantation. But in 1981 and 1982, cyclosporin was developed and added to the immunosuppressive regimen. And now on 3-drug immunosuppression, cyclosporin, azathioprine, and steroids, survival improved dramatically. And with improvement in survival, the numbers of patients listed and transplanted, as well as the numbers of programs performing transplantation, increased dramatically throughout the 1980s, peaking in the early 1990s. Now, in 1993, there was a conference that took place at the National Institutes of Health in Bethesda, Maryland, which looked at this time, the burgeoning field of heart transplantation, and in fact, the over and probably surplus of patients actually waiting for transplant. And they recognized that, in fact, there needed to be defined criteria for listing patients, that once you were on a waiting list, you could be delisted if you got sick or you actually improved. And there were clear indications for both getting patients on and taking patients off the list. And at this point, the numbers really flattened out and remained relatively constant for about 10 to 15 years as shown here, and similar data can be shown for the United States as well. Interestingly, while the numbers of transplants remained relatively flat up until about 2012 at about 22 heart transplants per year, you can see over the last few years this number has begun to rise again. And the reason for that, at least much of the reason, is due to really the unfortunate opioid epidemic, particularly in the United States, and the increasing numbers of donors that have become available because of the opioid epidemic and unfortunate overdose deaths. This is a research report that was recently published in the New England Journal of Medicine by Mandeep Mehra and colleagues, and you can see in the upper graph, in the purple bars, there is this steady increase in the numbers of donors dying of drug intoxication, whereas the other causes of donor death remain unchanged over that period. And here you can see on the bottom the donors who died from drug intoxication. This gradual uptick, particularly in the last 4 to 5 years, in the United States, whereas in Eurotransplant, this number has remained relatively flat over this time period. When we ask the question, how long do patients wait for cardiac transplantation? This is data from the OPTN, or the United States Registry, looking at patients at status 1A, the highest status, status 1B, a middle status, and status 2. These would be the least sick patients waiting for transplant. And you can see, unfortunately, that the median waiting times have increased significantly from the early 2000s into the present era, with patients who are 1A now waiting a median of nearly 400 days, as shown here, status 1B close to 500 days, and status 2 patients have a median waiting time of over 1,400 days. This system, however, is soon to change with a new allocation system that will become in place later this year. Each year, 12 to 18% of patients, unfortunately, will die or be removed from the waiting list because they're too sick for heart transplant. The United Network for Organ Sharing, or UNOS, was established in 1977 under the Health Services Act to facilitate fair, ethical, and efficient organ procurement and distribution. The membership of UNOS includes transplant hospitals, tissue typing laboratories, organ procurement organizations such as organ banks, and voluntary health organizations. In the early 1980s, UNOS was awarded a federal contract to implement a 24/7 organ matching service. And currently there are about 130 organ transplant programs organized into 11 regions, and that's shown here on this US map. You can see the 11 regions geographically. This is looking at the number of heart transplants by region in the most recent year of 2017. And just to show you a couple of the extremes, you can see one of the smallest volume regions is the New England region, shown, that's region 1, doing just about 150 heart transplants in 2017. On the other side of the country, in southern the United States, in particular Southern California, is region 5, performing over 500 heart transplants. Now, there aren't that many more centers in that region of the country, but there are some centers such as Cedars-Sinai and Los Angeles that are performing more than 100 transplants per year, but this is extremely uncommon. This slide shows the annual center volume. So the number of centers is shown here on the y-axis, and the average transplants per year is shown on the x-axis in this bar graph. And what you can see here is that about 75% of centers perform less than about 20 transplants per year, and very few programs are way over here on the right side performing 75 or more heart transplants per year. Well, why do patients come to heart transplantation? What's the underlying diagnosis of patients that are listed for transplant? A little over half the patients have non-ischemic forms of heart disease. These could be end-stage dilated cardiomyopathy or other familial or genetic forms of cardiomyopathy, such as hypertrophic cardiomyopathy, lamina-associated cardiomyopathy. A little over a third of the patients have typical coronary artery disease, so-called ischemic cardiomyopathy, and then much smaller percentages of patients fall into these other groups, such as adult congenital heart disease, 3% of patients for retransplantation, valvular heart disease, and some other uncommon diagnoses. There have been some changes in the characteristics of patients listed and transplanted over the last several years, and I just listed some of them here. Patients are becoming older. At one point, the upper age limit for transplantation was 60 or 65. Most programs don't have an absolute cutoff for transplant, although 70 is seen as really getting to the limit of where the benefit outweighs the risk of transplantation. In addition, patients are getting heavier. We know that obesity is a major problem in this country and around the world, and patients are heavier at the time of transplant listing. In addition, although it's a small group, the survival of patients with congenital heart disease into adulthood has also been increasing. In this country, what used to be 1 to 2% is now getting close to 4 to 5% of patients listed with adult congenital heart disease. Increased sensitization is also a problem that many of us struggle with, getting patients to transplant. And lastly, and probably the most relevant from a clinical standpoint, is the increasing use of mechanical circulatory support. And in most recent data, up to 50% of patients, either in the international registry or in the national registry, are requiring mechanical circulatory support as a bridge to heart transplantation. In the region of the country in which I practice, which is New England, I showed you the lower volumes and the longer waiting times. Greater than 75% of patients are bridging to transplant on mechanical circulatory support. And this just shows graph, this is international data, showing this increasing use of ventricular assist device therapy for bridging patients to cardiac transplantation. Well, what are the indications for heart transplant? And several of them are listed here. Some are more objective than others. Stage D heart failure is really looking at the ACC-AHA classification for level of severity of illness. Those patients with the most severe advanced disease, recurrent hospitalizations, inotrope dependent, these are the patients who have an indication for transplant. We also look closely at patients' exercise capacity, as this has very strong independent prognostic information. So patients with a peak oxygen consumption less than 12 mLs per kg per minute, or in younger patients less than or equal to 50% predicted, as long as it's an adequate test with an RER greater than 1.05. Other independent predictors are ventilatory inefficiencies, such as a VE/VCO2 slope greater than 35 to 40. Some programs do focus on survival scores, and if the estimated one-year survival is less than 80% using a prognostic score, this may be seen as an indication for transplant. Certainly patients who are deemed to be inotrope dependent or are now living on mechanical circulatory support, such as an LVAD, would have an indication for cardiac replacement therapy. As I mentioned, in general, we consider patients under the age of 70, although patients over the age of 70 have been transplanted with good outcomes, and ideally a body mass index less than 35 kilograms per meter squared. Now, an entire talk could be given on the contraindications to transplantation, and I've listed some of them here. Patients typically may be admitted to the transplant center or undergo an extensive outpatient evaluation to look for non-cardiac diseases or illnesses or comorbidities that may limit the survival post-transplant or lead to greater complications on immunosuppressive therapy. Pulmonary hypertension that's not responsive to vasodilator, inotrope, or even VAD therapy would be a relative or absolute contraindication. Diabetes itself is not a contraindication, but for patients who have long-standing disease with end organ damage or poor glycemic control would not be considered good candidates. An estimated GFR less than 30, generally these patients should be considered for combined heart and kidney transplant. Biopsy-proven cirrhosis is generally an absolute contraindication at most transplant centers, except in these perhaps select group of young adults with adult congenital heart disease in whom cardiac cirrhosis may be quite common, but could be acceptable at the time of transplant. Alternatively, these patients could be considered for heart-liver transplant. Peripheral arterial disease is not amenable to revascularization, would also be a concern. Any active neoplasm except for skin cancer should be considered a contraindication to transplant, although some programs are now moving forward and listing patients and transplanting them even with a recent diagnosis of prostate cancer if it's felt to be cured by either surgery or other aggressive forms of cancer treatment. Active infection with HIV or hepatitis B or C are relative, if not absolute, contraindications at most programs. Certainly in the older patients, assessment for frailty, as well as a very detailed psychosocial evaluation by a social worker and a psychiatrist for either a history of or current substance use would be an absolute contraindication. And finally, as I mentioned, patients who undergo transplant need to be adherent with their care. So a history of noncompliance or non-adherence with either medications or medical follow-up, lack of good support, or certainly dementia or other neurocognitive disabilities could be a relative, if not absolute, contraindication. Assessing the donor heart. Assessing the donor heart or accepting a donor heart is generally a two-step process. Most importantly, one wants to make sure that the heart is normal in structure and normal in function. So it's important to rule out any underlying cardiac dysfunction. Certainly for donors over the age of 30 to 40 or with a history of smoking or active cocaine use, coronary angiography is performed to exclude donor coronary artery disease. Secondly, the donor needs to be matched obviously by blood type and by body size, including considerations of gender mismatch in the acceptance process. Now, there is a physiological limit of ischemic time to about 4 to 5 hours, and I'll show you some of this data in just a couple of slides in terms of its impact on mortality. There is a protocol that many organ procurement organizations use called the Papworth Protocol for marginal donor hearts, which involves hormonal resuscitation with administration of thyroid hormone, steroids, and in some cases vasopressin. And there is increasing use as well of the so-called heart-in-a-box technology. This allows the blood to be transported while receiving warm blood perfusion, and this may allow the transport of organs from further distances and perhaps will optimize organ function post-transplant. But this remains to be determined in a randomized controlled trial. Well, as I mentioned, the original technique for performing cardiac transplantation was the biatrial technique. In the early 1990s, however, the bicaval technique, which is shown here, really became the standard of care for heart transplantation. You can see on the left here, looking down inside the chest, at the time the recipient heart is explanted, all one sees is a transected SVC, IVC, pulmonary artery, aorta, and then a small cuff of left atrial tissue containing the 4 pulmonary veins. And the donor heart is simply sewn in as shown on the right. Technically, this is not a complicated operation, but certainly, more importantly, the technical aspects lie in the removal of the recipient heart, particularly in patients who've had prior surgery, and certainly preservation of the donor heart in transplant and at the time of the operation. Well, the first question that most patients and family members will ask when considering heart transplantation is, how long can I expect to live after my transplant? This is data from the ISHLT, or International Registry, and similar data can be shown from the National Registry as well, just showing Kaplan-Meier survival by error going from the early 1980s through the 1990s and into the last decade of the 2000s. And what you can see here is that while the survival has indeed improved with each era, most of the change in survival has really occurred within the first 1 to 2 years post-transplant. And if you look at the most current era, on average, 1-year survival is about 85 to 90%. 5-year survival is about 75 to 80%, and 10-year survival is over 50%, with a median survival currently being around 10 to 11 years. As far as survival by diagnosis, this data is shown on this slide here. For the most part, patients with ischemic and non-ischemic cardiomyopathy, which are the 2 biggest subgroups of patients, do equally well post-transplant. The 1 or 2 outliers shown on this slide, one of the patients with congenital heart disease who have an early upfront mortality risk, but if you look at the blue curve here, late out, particularly if you look at conditional survival beyond a year, patients with adult congenital heart disease typically do better than some of these other groups of patients. On the other hand, patients undergoing their second or rarely third heart transplantation, the retransplantation category, which is a much smaller number of patients shown here in the green, has a statistically significant worsening on both short and long-term survival. This is data from the International Registry looking at risk factors for 1-year mortality. And this is a bit of a busy slide and maybe a little bit hard to read, but I'll call your attention to the lower part of the slide here, just showing again that patients with congenital heart disease versus cardiomyopathy tend to have a higher risk for 1-year mortality, but if they survive 1 year, do very well. And then patients requiring biventricular assist, temporary continuous biventricular assist, those patients who are on a ventilator going into transplant, needing other forms of temporary circulatory support, such as ECMO or right ventricular assist device support, these are patients who are at the highest risk of 1-year mortality following cardiac transplant. Those patients who need full cardiopulmonary support, that is, are bridging to transplant on ECMO, have the highest risk of mortality compared to patients on other forms of mechanical circulatory support, or patients shown in the yellow here who don't require either LVAD or inotropes. And as you can see here in the red line, the there's a very high upfront cost or risk of mortality in patients bridging to transplant in a short period of time on ECMO. I mentioned earlier on that about 75% of centers perform less than 20 heart transplants per year. And in general, if you're doing 10 or more, on average, your outcomes are acceptable. But when you look at programs that are performing 1 to 4 or 5 to 9 heart transplants per year in this analysis, you can see that the risk of early graft failure is significantly higher compared to programs doing anywhere from 10 to 50 transplants per year. Additionally, those programs doing 50 or more transplants per year actually tend to have the best outcomes relative to early graft failure. Ischemic time is also a strong contributor to early graft failure. This is just showing that patients who receive a donor heart with anywhere from 4 to 6 or greater than 6 hours of ischemic time have a much higher incidence of early graft failure compared to patients in the green and the purple line here who are receiving hearts within 2 to 4 hours. And finally, donor age is clearly associated with early graft failure. You can see here that the inflection point is around age 30 to 35, and once the donor is over the age of 40, there is a significant increased risk of early graft failure. Well, why do patients die following transplant? And it tends to be dependent on time. So within the first 30 days, occasionally, although rarely, patients will die of acute or hyperacute rejection. Between 30 days and 1 year, mortality is typically related to infection, particularly given the higher levels of immunosuppression. And then beyond a year, cardiac allograft vasculopathy and malignancy tend to be the most common cause of late mortality. And we'll talk a little bit about both these issues in just a second. As far as rejection is concerned, all patients undergo standard surveillance using endomyocardial biopsy of the right ventricular septum, using a disposable catheter to look for evidence of rejection. More typically, these biopsies are performed frequently early post-transplant and then become less frequent as patients get further and further out from their transplant date. The working formulation for diagnosis of heart rejection was revised in 1990. This is an update that was published in the Journal of Heart-Lung Transplant in 2005, just showing 3 grades of rejection. 1R in the upper left here would be mild rejection with one focus of myocyte necrosis and inflammatory cell infiltration with predominantly lymphocytes. In the upper right, this would be moderate or 2R rejection, showing 2 or more foci of myocyte necrosis. And then most concerning, of course, would be severe or 3R rejection, shown in the bottom here, with diffuse infiltrates with necrosis and may have associated vasculitis, edema, and hemorrhage. Typically, 3R rejection can sometimes be associated with hemodynamic compromise and requires in-hospital aggressive immunosuppressive therapy. Moderate rejection, such as 2R rejection, can sometimes even be treated as an outpatient with an oral pulse of steroids. Most programs would not treat mild forms of rejection, but rather perhaps make alterations in outpatient immunosuppressive doses. There has been growing interest over the last decade in using other biomarkers to try to define or diagnose either the rejection or the lack of rejection. And gene expression profiling has been studied in a randomized clinical trial that was published in the New England Journal of Medicine in 2010, in which over 600 patients between 6 months and 5 years post-transplant were randomized to either a standard biopsy schedule or a gene expression profiling to rule out or to assess low-grade risk of rejection and therefore obviate the need for biopsies. What you can see here on the left, the primary event rate, was really no difference in this non-inferiority trial. This is looking at rejection. And on the right, as far as frequency of biopsies, those patients who did receive gene expression profiling had much fewer biopsies compared to those patients who underwent serial biopsies per routine protocol. When asking about maintenance immunosuppression at follow-up, this is data from the ISHLT registry. If you look, for example, in the red bars, this is looking at maintenance immunosuppression at 5 years. You can see the majority of the patients are on tacrolimus as opposed to cyclosporin. Most patients are on mycophenolate mofetil, as well as about 50% of patients are still on low doses of prednisone. Cyclosporin, sirolimus, and azathioprine are much less commonly used in the current era. Now, cardiac allograft vasculopathy, unfortunately, is really the holy grail of transplant medicine, and an area that unfortunately we have made little progress in over the last 2 or 3 decades. Approximately 30 to 50% of 5-year survivors will have at least one vessel with greater than 50% stenosis, and this is typically a diffuse immune-mediated process in which vessels taper and ultimately are occluded. This is the most common cause of late graft failure. Variable clinical presentation includes patients being asymptomatic, and they can even have myocardial infarction due to denervation and therefore not have any symptoms, or presenting with severe heart failure. Risk factors are shown here, including history of coronary disease, hypertension, or dyslipidemia. Those recipients who are younger or receive an older donor, and early rejection is also associated with late risk of cardiac allograft vasculopathy. Unfortunately, the treatments for CAV are not very good, including revascularization, retransplantation, some medical therapies that have been shown to attenuate or slow the progression of CAV, as well as other immunosuppressive agents such as sirolimus and everolimus, in which there is some data suggesting that these drugs may attenuate the process of CAV, but have other toxicities and intolerances that make them difficult to use routinely in the transplant population. This graph just shows a freedom from malignancy. You can see here that the freedom from any malignancy in the blue line is about 50% at 15 years, with a skin cancer and lymphoma or post-transplant lymphoproliferative disorder being the 2 most common forms of cancer that we see in patients. These are just a few examples. This is an example of a patient with multiple squamous cell carcinomas involving the head and neck, and this can be initially just an aesthetic issue, but can become quite invasive and disfiguring. Here are 4 other examples shown on imaging of malignancies that can occur post-transplant. In the upper left is a CT scan from a patient presenting with metastatic colon cancer. In the upper right, you can see a large mediastinal mass. This is a patient who had been treated 20 years before transplant for testicular cancer, and 5 years post-transplant presented to clinic with fatigue, a cough, and was found to have recurrent seminoma in the chest that was thankfully responsive to a combination of radiation and chemotherapy. In the bottom right, you can see here a large mass in the right-sided kidney showing renal cell cancer. And finally, in the lower left was an unusual case of a patient with PTLD involving the allograft itself that unfortunately was advanced and was not responsive to lowering of immunosuppression and chemotherapy. Survival after the report of malignancy within 3 years of transplant is shown here. Skin cancer doesn't seem to have a significant impact on long-term survival, whereas lymphoma or PTLD clearly has a significant impact on survival, as shown in these curves. Other common morbidities that are seen late post-transplant, if you look at data out to 8 years, virtually all patients are being treated for hypertension, over 90% dyslipidemia. Renal dysfunction is also quite common given the use of calcineurin inhibitors, with about 1/3 of patients having some degree of renal dysfunction and 4 or 5% of patients requiring dialysis at 8 years. Diabetes, which is common both pre-transplant, is also common post-transplant in over 1/3 of patients. This is an older study just pointing out that I mentioned that patients are increasingly obese going into transplant, and what we tell our patients that on average, patients following transplant within 1 year will gain anywhere from 20 to 25 pounds, compared to only about 10 pounds in the kidney transplant population. So we have to encourage our patients to be very careful, particularly when they're on steroids, to watch their appetite and to maintain a healthy diet to avoid this significant weight gain. The reason that we're concerned about obesity is that obesity can affect post-transplant morbidity acutely, increasing the risk of infection, poor wound healing, and high-grade rejection, and chronically contributing to problems such as hypertension, cardiac allograft vasculopathy, as well as obstructive sleep apnea and cholelithiasis. Well, how do patients do in terms of exercise capacity? This is an older study that we published many years ago from data at our center looking at exercise capacity post-transplant. And it turns out that patients are limited by their change in heart rate. Because they're denervated, patients have a higher resting heart rate and a lower peak heart rate, such that the delta heart rate, as shown on the left, is dramatically blunted compared to control patients. And this contributes to abnormal peak oxygen consumption that is improved at 1 year, but doesn't change out to 3 and even 5 years in other data that's been published. Despite the reduced heart rate response to exercise and peak oxygen consumption on a cardiopulmonary exercise test, functional status post-transplant tends to be excellent. And if you look at this data out to 3 and 5 years, the vast majority of patients are functioning with very little limitation in their activity, with just a small percentage of patients requiring either support, partial support, or total support because of some complication that may have developed after their transplantation. Well, I think one of the things that I've learned over many years in taking care of patients with advanced heart disease and helping them bridge to cardiac transplantation is that everything is indeed possible. And these are just some of the faces of patients and family members that I've had the immense privilege of taking care of over the past many years, who have lived really amazing lives with the gift of a donor heart, having families, going back to work, running marathons, getting married, and seeing their children married as well. So with that, I'm going to end the formal part of my talk, and I will go on now to the two post-discussion questions. And we'll start with question 1. A 44-year-old woman, status post-heart transplant 3 years ago, presents to the emergency department with cough, dyspnea, and fever. Chronic oral immunosuppression includes tacrolimus 4 milligrams twice daily, mycophenolate mofetil 1,000 milligrams twice daily, and prednisone 5 milligrams once daily. A chest x-ray reveals a cavitating lesion in the right upper lobe. A galactomannan level is elevated to 2.5 nanograms per ml, and diagnostic biopsy is planned to confirm a suspected diagnosis of invasive pulmonary aspergillosis. While waiting for the biopsy, a transplant infectious disease consult recommends initiating therapy with fluconazole. Which of the following is the most appropriate next step in the adjustment of background immunosuppression? A, increase tacrolimus dose to 5 milligrams twice daily and recheck trough level. B, decrease tacrolimus dose to 3 milligrams twice daily and recheck trough level. C, increase MMF dose to 1,500 milligrams twice daily and monitor complete blood count. D, decrease MMF dose to 500 milligrams twice daily and monitor complete blood count. Or E, decrease prednisone to 2.5 milligrams once daily. I'll give you a couple of seconds to think through this question. The correct answer is B, decrease tacrolimus dose to 3 milligrams twice daily and recheck the trough level. On the next slide is an explanation for this correct result. Again, when adding any therapy in patients post-heart transplant, one must always consider the potential effect of drugs on immunosuppressive therapy, particularly drugs such as tacrolimus or cyclosporin. In fact, in this case, decreasing the dose of tacrolimus would be the most appropriate next step while the patient is being treated with fluconazole. Invasive pulmonary aspergillosis can occur at any time following heart transplant, but is more common late after transplant. When we talk about drug-drug interactions, fluconazole, a potent antifungal agent with a high degree of activity against Aspergillus species, is also a strong inhibitor of the cytochrome P450 system. It's important to remember that tacrolimus is a drug that is metabolized by the same enzyme system. Therefore, initiation of fluconazole requires a decrease, not an increase, in the dose of tacrolimus with follow-up testing of the trough level, typically a 12-hour trough. Fluconazole does not affect the metabolism of mycophenolate mofetil. Furthermore, there would be no indication for changing the dose of chronic maintenance corticosteroids. We'll move on now to question 2. A 58-year-old man with ischemic cardiomyopathy is listed for cardiac transplant. Relative contraindications include obesity with a body mass index of 33 kilograms per meter squared and mixed pulmonary hypertension with a pulmonary capillary wedge pressure of 24 millimeters of mercury, transpulmonary gradient of 15, and pulmonary vascular resistance of 4 Wood units. Hemodynamic parameters improved on a chronic infusion of milrinone, an INO vasodilator, and he loses 20 pounds. After 3 months of waiting, he receives a donor heart from a 35-year-old woman of similar height and weight. Soon after arrival to the intensive care unit, he is extubated. The next morning, central venous pressure rises to 18 millimeters of mercury and urine output decreases. Blood pressure is 102 over 78 millimeters of mercury. Pulmonary artery pressure is 60 over 30. Pulmonary capillary wedge pressure is 16 millimeters of mercury, and the cardiac output is 3.8 liters per minute. In addition to IV milrinone, epinephrine, and furosemide, which additional therapy would be most helpful in improving hemodynamic parameters in this specific clinical setting? A, IV dopamine. B, IV methylene blue. C, inhaled epoprostenol. D, IV norepinephrine. Or E, IV chlorothiazide. I'll give you a minute to think about this case and think about the most appropriate answer. The correct answer in this question is C, inhaled epoprostenol. It's important to remember that patients are at risk for early right heart failure post-cardiac transplant. This patient was at increased risk because of baseline pulmonary hypertension and because of the fact that the donor was a woman of similar height and weight. This is the explanation for the correct answer to the question. Most heart transplant recipients will require short-term treatment with inotropic and vasopressor agents in the immediate postoperative setting to maintain hemodynamic stability and end organ function. As was suggested, this obese man with preoperative pulmonary hypertension who received a donor heart from a woman is at risk for and develops early right heart failure manifested as elevated central venous pressure, low cardiac output, and worsening renal function. Milrinone, an IV INO vasodilator, is particularly useful in this setting to increase right ventricular contractility and reduce pulmonary vascular resistance, while IV diuretics help to reduce right ventricular preload. Despite this treatment, the patient still has elevated pulmonary artery pressures and pulmonary vascular resistance. Inhaled epoprostenol is a selective pulmonary vasodilator that can be used with milrinone for additional lowering of the pulmonary vascular resistance, and therefore is the correct answer. Methylene blue has been used in the setting of postoperative vasoplegia, but the current presentation is more consistent with right heart failure. IV norepinephrine or high-dose dopamine would be more useful for distributive shock. Finally, IV chlorothiazide could be added to furosemide for a synergistic diuretic effect, but would not be the next best treatment option. So in summary, I've tried to explain that heart transplant is indeed a viable long-term option for patients with truly refractory or advanced heart failure. Over the last 2 to 3 decades, we've seen improved survival despite the fact that we are enlisting and transplanting older and sicker patients using hearts from older donors and with longer waiting times. Most notably is the increasing use and experience with mechanical circulatory support as a bridge to transplant, and even the use of ECMO, which, as I showed you, is associated with a very high risk of early graft failure and mortality. Unfortunately, little progress has been made in the post-transplant setting in preventing rejection without excess risk and reducing long-term morbidity, especially that associated with cardiac allograft vasculopathy and malignancy. Xenotransplantation, or transplanting organs from genetically engineered or modified animals into patients, is still undergoing investigation, and whether this will ever be the future of cardiac replacement therapy remains to be determined. One of the hopes, of course, however, is developing smaller and more durable mechanical assist devices that could be used for long-term destination therapy.